Let's cover the mechanisms of action of clonidine and guanfacine. Both of these are considered alpha-2 agonists. There are subtle differences between both of them though. So when we think about alpha-2 agonists, the alpha-2 receptors, there are presynaptic alpha-2 receptors and postsynaptic alpha-2 receptors. We know that postsynaptic alpha-2 receptors are stimulated by noradrenaline. Presynaptic autoreceptors reduce noradrenaline. Now, clonidine as an agent has alpha-2A, alpha-2B, and alpha-2C agonistic activity. Guanfacine is a much more selective alpha-2A agent. It's 15 to 20 times more selective for alpha-2A than any of these other receptors. So let's look at clonidine. Clonidine is a greater presynaptic alpha-2A agonist. And we know that that means by acting at the presynaptic end and by activating this autoreceptor, it will have the combined effect of reducing noradrenaline. So in the frontal cortex, what it essentially does in the treatment of ADHD is it will optimize the level of noradrenaline in this part of the brain. The other areas where it reduces hyperarousal by reducing the level of noradrenaline, which is very, very helpful in the treatment of, say, post-traumatic stress disorder or sleep disorders, is by reducing the level of amygdala activity. Because amygdala has a very, very high innervation of adrenergic neurons, noradrenergic neurons from the locus ceruleus. So by prescribing clonidine, we can directly target this area, reducing noradrenergic activity. So therefore, clonidine is often prescribed in pediatric insomnia. It's also beneficial in nightmares in post-traumatic stress disorder. And this happens through the action at the presynaptic end with the overall effect of reducing noradrenaline. It has some mild postsynaptic alpha-2 action, which of course we know can promote cognition, strengthen networks, increase vigilance. But this action isn't as strong as guanfacine. In terms of side effects, clonidine has one additional receptor known as the imidazoline receptor. This receptor is responsible for the hypotensive effect of clonidine. Clonidine tends to have a greater hypotensive effect than guanfacine due to this particular receptor activity. Now, when we think about clonidine, we've talked about ADHD, sleep, PTSD. It also has benefits in pain medicine. The reason being is overall pain perception is reduced when amygdala activity is reduced, when hyperarousal is reduced. But clonidine, through its action on the alpha-2 receptors in the dorsal horn neurons, will promote anti-nociceptive activity. So reduction of pain sensation overall. Clonidine also has pain benefits through the reduction of sympathetic arousal by reducing the amygdala hyperactivity, the noradrenergic hyperactivity, but it also through the postsynaptic alpha-2 activation. Even though it's mild, it can provide those benefits by activating the noradrenergic pathway in that descending spinal nociceptive pathway, thereby overall reducing pain sensation. Guanfacine is a selective alpha-2A agonist and is therefore prescribed in ADHD because we know that what we're trying to do in ADHD is to strengthen those networks by activating the alpha-2A receptors. Because it does not have these other aspects of alpha-2C or alpha-2B and does not have the imidazoline receptors, it does not have a significant hypotensive effect. Blood pressure should be monitored, but one doesn't have to be as cautious as with clonidine. Generally, with clonidine, we find that when it started at 50 micrograms, increased to 100 micrograms, blood pressure drops aren't as significant unless the person is hypotensive in advance. It can provide advantages, for example, in PTSD, where individuals have significant hypertension in many cases. So overall, when we look at the presynaptic and postsynaptic alpha-2 agonists, they have benefits in ADHD, sleep, clonidine more than guanfacine, antihypertensive effects, clonidine more than guanfacine, and guanfacine tends to be prescribed and is evidence-based in ADHD in children. It's FDA approved as well and also approved in Australia because of its selective alpha-2A agonist activity. So where can we use it in ADHD overall? Sometimes when there are predominant sleep difficulties, because we know that individuals with ADHD tend to have very, very high comorbidity with sleep, one could consider starting off with alpha-2 agonists as opposed to stimulants. That's one possibility. Secondly, when individuals experience significant hyperarousal symptoms in the treatment of ADHD, one can counteract that through clonidine or guanfacine. Both of these agents are evidence-based in the treatment of tics or Tourette's disorder. And we know both these conditions are comorbid in ADHD. If there are treatment-emergent tics in ADHD with stimulants, these agents are also used when there are treatment-emergent tics with stimulants. These are non-stimulants, so therefore, if stimulants are contraindicated or have significant side effects, one can think about these agents as well overall in the treatment of ADHD.